So in this presentation we're going to discuss American Heart's 2010 guidelines and from ACLS for the adult tachycardia with a pulse. So as you're assessing your patient, when your patient has a heart rate of greater than 150, we need to consider that it is the heart rate, the tachyarrhythmia, the heart rate that is part of, if not all of, the problem. And we're going to try to identify and treat the underlying cause with standard airway and breathing management, oxygen if your patient has an O2 saturation of less than 94%, or if you're unable to get an accurate measurement, if you believe there's a chance that there's hypoxemia. And then a cardiac monitor to identify the rhythm, which probably means a 12 lead, or at least multiple leads, to get a good view and identify the rhythm. And continuing monitoring the blood pressure and oximetry. So the number 3 box in the algorithm, the pink box, is directing us to determine if the patient's symptoms are severe. Are they unstable? Do they have hypotension? Are they acutely altered? Are there clear signs of shock? Is ischemic chest discomfort present, which almost certainly means a 12 lead will have to be involved? Are they in acute heart failure? These are the unstable patients. If so, we're going to move toward either synchronized cardioversion or, in a few cases, a Dennison therapy. If not, then we're going to move on down to more conservative therapy. So we want to talk next about box number 4, the blue box, and talk about synchronized cardioversion and the specific issues involved there. So in these very unstable patients, if the patient's heart rhythm is regular and the complex is narrow, then it is acceptable for us to consider a Dennison rather than cardioversion. However, if the patient's rhythm is irregular, or if that complex is wide, and the patient's very unstable, with hypotension, ischemic chest discomfort, altered mental status, signs of shock, acute failure, then we're going to need to do synchronized cardioversion. And as you can see, there are several different energy levels, and this can become confusing, so we want to try to clarify that. So in these unstable patients, where cardioversion is the option we're going to choose, we're going to synchronize cardiovert in both cases, whether it's wide or narrow, in a regular rhythm. And the range on the narrows is 50 to 100 joules, and the setting on the wide complex is 100 joules. So as long as we are regular, then 100 joules is a legitimate answer. When the rhythm is irregular, we're still going to sync on the narrow complex, but we're going to go to the more of a defibrillation level of energy. Now again, it's still synchronized as long as it's narrow and irregular. This is typically an AFib. Once it becomes wide and irregular, we no longer are going to sync. We're going to use unsynchronized cardioversion. We're actually going to defibrillate a patient with a pulse. And again, the energy level is 120 to 200. So as long as it is regular, 100 is a legitimate number. Once it becomes irregular, then 120 to 200 is the appropriate energy setting, and it's unsynchronized if it is wide and irregular. So coming back for a moment to the previous screen, box 4, the blue box, talking about synchronized cardioversion or cases where you can consider a Dennison. These are for, again, the unstable patients, significant symptoms, altered mental status, shock, hypotension, heart failure, clearly ischemic chest pain. You can consider a Dennison in the case where it is regular and narrow. That isolated case of regular and narrow. Once it becomes irregular or it becomes wide, then Dennison is no longer considered an option in these very unstable patients. Now let's go back and consider, what if your patient has some symptoms but they're not the severe symptoms? We don't have the hypotension. We don't have the acutely altered mental status, the signs of shock, ischemic chest discomfort, acute heart failure. This patient is not horribly symptomatic. So now we're working our way down. And the next question we're supposed to ask is there a wide QRS? If there's a wide QRS, then we're supposed to consider some other factors. We're supposed to consider medication therapy. So IV access, a good 12 lead for a good clear assessment of the rhythm, and then we can consider a Dennison. We can consider antiarrhythmic infusion, meaning amiodarone, procainamide, a beta blocker. Consider expert consultation. That should be something at this point, for field providers particularly, where we have a patient with some symptoms but not horribly severe symptoms. They're not hypotensive yet. They're not acutely altered yet. They're not in shock yet. They have ischemic chest discomfort possibly, but we're not totally sure. This is a person who has some symptoms, but they're not unstable enough for us to go down the cardioversion road. Then we should consider medications, and considering expert consultation at this point in this complex patient would be an extremely wise move. We wouldn't want to try to manage these patients alone. Certainly we can, but why? Why try? So this would be an excellent time to get on the phone, get your transport on the way, and then have a good consultation with a good description of your EKG. And so now to finish the algorithm, looking at the green box down here at the bottom, box number 7, we're going to need IV access and a 12 lead, of course. We may try some vagal maneuvers to see if we can slow this down a little bit. We can try some Dennison as long as we've still got a regular rhythm. Beta blockers, calcium channel blockers. Again, consider expert consultation. So this is the patient who has a tachyarrhythmia that caused us to begin this analysis in the first place. But we determined that their symptoms were not so severe that cardioversion would be a route that we're going to try to go, and their QRS is not wide. So narrow complex, an SVT, and the patient has some symptoms but not very severe symptoms. And they're going to suggest expert consultation. I think many protocols will allow vagal maneuvers and a Dennison in this case. Some will perhaps go all the way to beta blockers or calcium blockers, but again, expert consultation would be advisable. So here's the whole algorithm again, starting from the top where you enter the algorithm believing that the heart rate of greater than 150 is part of, if not the whole problem. Do some basic airway breathing, O2 therapy, cardiac monitor, probably 12 lead, some BP and oximetry measurements, and then there's a determination about how severe these symptoms are. We're looking again for hypotension, acutely altered mental status, some signs of shock. Is the chest pain apparently ischemic? Are they in acute heart failure? If that's the case, we're going to need to head down the cardioversion road, and that we're allowed to consider a Dennison as long as this very symptomatic tachydysrhythmia has a narrow complex and is a regular rhythm. Then a Dennison is still an option if it's not regular, or if it is a wide complex. Then cardioversion is going to have to be the answer, and in the case of wide and irregular, it's unsynchronized cardioversion, it's defibrillation. So electrical therapy is what we're going to use for these very unstable patients, with the one exception of the narrow complex rhythm where a Dennison would be an option. If we've determined that there are not significant and severe symptoms from this tachydysrhythmia, Then we look for the QRS width. If it's wide, then we're still going to consider some medication to do something about it. If it's not wide, then we're going to consider some vagal maneuvers, maybe some Dennison, maybe some of the same medicines. And in any case, considering expert consultation is emphasized. There are various dosages for the cardioversion levels. Once we're going to go down the Dennison road, then that's 6 and 12. That the old second dose of 12, the old 6, 12, and 12 is no longer in ACLS, but expert consultation might suggest that second dose of 12 be given. Procainamide is back in. I want to do a whole separate discussion on procainamide. Amiodarone, given in certainly a different way than in cardiac arrest. In this case, in a infusion, a bolus infusion followed by a maintenance drip, and we want to do a separate discussion on that. And then sotalol or other beta blockers may be an option. So this is the algorithm overall, and this has been a relatively short summary with an emphasis on the use of Dennison in certain cases of unstable patients and the cardioversion levels.